Hello everybody, I am Dr. Laxman Salve, consultant proctologist and general surgeon practicing in Apollo Spectra Hospitals, Tardeo and Chembur, Mumbai. So today we are going to discuss a very important topic in proctology, fistula in ano. Many people are frustrated with this disease and they are not getting cured or they are afraid of having it recurrence, and this takes long time for curing. So this becomes that way an important topic for discussion and to resolve so many queries. This is a very notorious problem because whatever expertise you apply or whatever new technology you apply, there are again always chances of recurrence. What we do is with the expert hands and advanced technology, we reduce the chances of failure, that is, we increase success rate with the new technology and adequate expertise of the surgeon. So both are equally important, expertise of the surgeon and newer technology to manage different types of fistula. So now what is fistula in ano? Fistula in ano is something called as we can say as a tunnel between the two cavities. So the rectum or anus is connected with the exterior through a tract or a tunnel. Now this tunnel can travel in any ways inside the sphincter complex to give rise to different types of fistulas. And then how it travels inside the sphincter divides or makes it to different types of fistulas. So if the internal opening is there, this is anus and there is internal opening here and the external opening is here on the skin. So this fistula, how it travels, whether it travels straight, whether it travels in a lower level, whether it goes on a higher side and then comes back, where does it form an abscess and how does it travel? That is how we classify these fistulas into different types of fistulas. So these fistulas may travel on a lower side or they can be on a higher side. They can travel between the two sphincters. They can encompass whole of the sphincter. They can just travel through lower muscle fibers of the sphincter. So depending on that, we classify mainly them as into two classifications, low fistula and high fistula. When the fistula travels through the external sphincter in the lower 1/3 of the external sphincter, then we call it as low fistula, and anything other than this is called as high fistula. So we'll come to the etiology or reason why it happens. So fistula happens mainly because of infection of the gland which is situated between the two sphincters. Now these glands are something like salivary glands we have in the mouth. These glands secrete some fluid which is a lubricating fluid or keeping the anal area lubricated and a little moist one. So these glands open through a duct into the anal canal. But somehow, if this gland gets infected by the infection, which most commonly happens because of the fecal matter itself, and then if it gets entrapped in the duct which goes to the gland, and then it blocks that duct and that gland gets inflamed and swollen and infected. And then that infected gland forms an abscess and that abscess can break out through the external sphincter into the skin, and this skin opening can be anywhere. It may be around 2 to 5 centimeter around the anal area or away from the anal area, maybe up to the maybe in the groin, maybe in the thighs, maybe in the long way in the buttocks, or sometimes toward the knee joint also, or on the anterior abdominal wall also. So it can open anywhere depending on how easy road he gets. but the main pathology is in the sphincter complex. And to avoid this happening again inside during surgery, a surgeon has to be expert in how he tackles this anal gland and how he tackles the internal opening of that fistula. And in tackling this internal opening and the tract of the fistula sometimes become difficult with the open method, and then surgeon has to think often whether he should cut open the sphincters and sacrifice those sphincters, and in that way patient may land up into incontinence, that is loss of control of stools. And on the contrary, on the other hand side, he may try to preserve the sphincters, but then he may not be able to remove those infection glands, those he may not be able to address that tract completely, and then it can lead to a recurrence. So it is a balance between the incontinence and recurrence, and at the same time we have to see to that patient remains pain free or with less pain after surgery. His life doesn't get hampered, and for this we need to use multiple newer technology, newer methods of dealing with this complicated type of fistulas. So before going to the management of fistula in ano by different methods, we have to understand basically why this particular fistula in that particular patient has happened. So we have to understand what is the physiology of that person as far as concerned with the evacuation, defecation details. How much is the anal tone of the sphincter muscles there? Sometimes this fistula happens secondary to the fissure in ano. So what is fissure is sometimes this patients pass motion hard, and then this area is this outside portion or the outermost portion of the anal area gets cut, and if repeatedly if it happens and patient neglects this disease, then this fissure can develop underlying an abscess, and this abscess can burst out onto the skin to form a fistula in ano. Usually these types of fistulas are low fistulas, and in these cases we have to see to it that we are treating fissure at the same time we are doing sphincterotomy. That is, sphincterotomy is the procedure where internal sphincter is cut till the level of fissure in ano, which is say around half a centimeter or so. So even if we are cutting the sphincter, we are just cutting half centimeter or less than half centimeter of the internal sphincter, which is of not much significance in the lowermost part. So we have to treat that fissure and do internal sphincterotomy to avoid such fissure formation again, and hence fistula also. Here we can do fistulotomy also, or we have different methods, fistulotomy or fistulectomy, depending on the surgeon's choice. We also have to understand why this fistula has happened. So usually these fistulae happen because of the habit of patient having constipation. So what happens during constipation? If the anal tone of this person is high and he is constipated and he is not passing motion easily out, his motion is hard, and if he is straining to pass motion, and if the anal tone is high, this fecal matter has high chances of traveling into the anal duct and getting it blocked and formation of fistula or infection of the anal gland. So we have to see to that patient doesn't get constipated again. Patient, even if he has the habit of constipation, we have to see that his if there is a prolapse of the mucosa, which is causing retention of the fecal matter, is also addressed. We have to see to it that if the patient's internal sphincter tone is on higher side, we have to do internal sphincterotomy and then do rest of the surgery. So now if we come to the management of the fistulae, here there are mainly two procedures. We can say as fistulotomy and fistulectomy. So fissulotomy is something just lay open the fistula tract and then it heals of its own by secondary intention over a period of say around 6 to 8 weeks, depending on the nutrition level of the patient, depending on the infection at that site when you do the surgery. So it heals with fissulotomy. Now fissulectomy is a procedure where you are taking out the fistula tract completely from external opening to internal opening. And this fissulectomy often leads to very high success rate. But while doing fissulectomy, when we are dealing with the tract of the fistula in the sphincter complex, we need to see that we are not damaging sphincter muscles and patient will not be incontinent after surgery. And here comes the role of different newer technologies. So since this fistula differs from patient to patient and it differs in its different types, so not a single method is a proven method, and you cannot say that this method has given 100% result for everybody. So there are different methods of treatment for fistula nano, like using laser surgery, using laser to treat fistula. There is something called as lift, where we are cutting the fistula tract between the two sphincters and ligating at in the intersphincteric plane and removing the external part of the fistula is removed and internal part is ligated. Then there is new method called as which we do with the fistuloscope, where the fistula tract is curated and then a fistuloscope is passed inside the fistula, and then you see the fistula, you see the lining of the fistula, you curate it out and then treat it as per different methods. Like you can just curate it out and sometimes you can close, sometimes you can just laser it, or sometimes you can put some collagen or something material there to obliterate that tract. Now if I talk about use of laser in fistula, which we do commonly in our institute, where we treat this fistula with laser in complicated cases. By this I mean when the fistula tract is traveling in the sphincter complex very haphazardly, or it is going on the top of the sphincter where you cannot cut, you cannot think of cutting sphincter muscle. Here in this way, in these cases, laser probe being flexible, we can pass this laser probe through the fistula tract and we can ablate this tract. But there are different ways, like you have to decide how much is the diameter of the fistula, how much is the length of the fistula, where is the abscess cavity, and depending on that we have to use laser. But if the tract is small, of small diameter, is going very high through the sphincter complex, we need to remove this debris from the fistula tract, we need to remove the infection, and we can ablate the fistula tract very effectively with the radial fiber of laser, and by which it will burn the mucosal lining of, the unhealthy mucosal lining of that fistula tract, and then that fistula tract of a small diameter collapses and collapses completely and heals. But it may not collapse completely if the diameter is of higher side, if the diameter is big. But then still it is of use because it is ablating the whole of the tract mucosa in 360 degree. So there are very less chances of something remaining behind, some infection remaining behind, and if there is abscess cavity or something, that also gets ablated. Now what is the benefit of laser is, laser energy damages the structure or ablates the structure about 3 millimeter in the depth of 3 millimeter only. So if we use different energy other than laser like cautery or something, it may ablate the surrounding structures also, which are not required to get ablated in a bigger way, and then it may lead to more damage to the sphincters. It may lead to delayed healing, and if there is delayed healing, there are chances of infection, and then this in final can lead to recurrence also. But using laser is not that easy also. So it need expertise. Anybody cannot use it in the first go. It has to be used under the guidance of some expert who is routinely doing it. The person should know that what is the thing where you should not use laser, where is the thing where you should definitely use laser, what should be the intensity or joules of the laser put, energy levels put, and then only you can use this laser safely. Otherwise, if it is used inadvertently, there are known complications happening in the management of fistula treatment with the laser. So right selection of the patient, right selection of the disease, right way to do the laser ablation of the fistula tract is very important, and that comes with the expertise of the surgeon. It's not only about the technique, it's about expertise of the surgeon, it's about selection of the patient also. So these are common methods of treating fistula in different way. When the fistula is very complicated, like the fistula is traveling or encasing whole of the sphincter muscle, or it is having a deep-seated abscess cavity, and that is not traceable. Like you cannot trace either with open method or by laser or fistuloscope, and there is a big abscess cavity underneath inside. Then in such situation, with expert hands, I'm telling, in expert hands, we can lay open the sphincter complex also, and then after addressing this cavity, after curating this infected cavity and draining out the pus, we can close the sphincter primarily and to achieve his continence again. But this has to be done in expert hands, and nobody can, who doesn't have experience in closure of the sphincter muscles, should not dare to do this, and he should take help of the expert to deal with such complicated fistulas. These fistulas are of different types, and success depends on how you are dealing with the internal opening, whether are you taking out those infected glands or not. Other very interesting presentation of these fistulae is presentation with perianal abscess. So these patients present with a big abscess, they have a lot of pain, and they come to a surgeon that they are having big swelling in the perianal area, and they are not able to understand what it is exactly. And these perianal abscesses are mostly due to the underlying fistulae. They are breaking out open. Just before breaking out open, they are getting infected and forming an abscess. So treating these perianal abscesses is also very important, because most of the surgeons go for drainage of abscess first, and then they just do the drainage and don't treat the underlying fistula. Reasons are, sometimes they are not aware how the fistula tract is traveling, where is the internal opening, because of inflammation, because of swelling there, because of lot of edema and infection. Every surgeon may not be able to detect that underlying fistula tract and internal opening. But in my case, or in our Apollo Spectra Hospital, what we do is, most of the time we are able to locate this internal opening and treat the underlying fistula at the time of treatment of perianal abscess itself. But if a person is not expert in that, he may just drain the abscess and keep an eye over that patient, so that if he develops fistula, this has to be treated in the subsequent setting, and patient has to be told that he may develop with a proper fistula tract and may come back again, and then this needs to be treated. When your patient comes to us, as we know the anatomy in detail, we are able to locate internal opening and fistula tract in those cases of perianal abscess, and we try to give them best of the cure of fistula and perianal abscess in one sitting, so that they don't need to go for second sitting and subsequent surgery for fistula and ano. This again needs expertise, because this finding internal opening is most of the time difficult. Even during surgery for the fistula and ano, finding internal opening may be a challenging issue for surgeons sometimes, because that internal opening may get fibrosed. It may have a very different notorious tract, so that you are not able to identify where is the internal opening. And if the internal opening is not dwelled properly, patient can have recurrence. Another reason is, if the abscess cavity is not dealt properly, patient can have recurrence. If the part of the fistula tract is left behind with the infected tissue, it can recur again. So, as I told you, as the surgery is important, equally important is the post-operative follow-ups. So, during post-operative follow-ups, patient has to be equally and very importantly evaluated by the surgeon to see if there are any chances of recurrence, to see if there is something remaining behind, and if the wound is not healing properly and it is having unhealthy granulation tissue often, then he needs to think why this is happening, and then he has to address these issues. Usually these fistulae patient, if treated properly with all attention, usually should heal within a period of 6 to 8 weeks or sometimes 10 weeks. So this is what is happening with our patients. But some complex fistulae may linger, and they may take sometimes 3 months also for complete cure. Another reason for having recurrence of the fistula is the patient is not diagnosed properly how the tract is traveling. MRI is the best investigation to diagnose fistula tract, fistula disease, and to locate the fistula tract. If both can happen, a doctor may not do MRI and directly go for surgery, and he may not be able to identify the side tracts, and patient will land up into recurrence. On the other hand, patient comes with MRI, but surgeon is not able to reciprocate that MRI findings into the patient, and something is left behind. So MRI is good tool of diagnosis, but in expert hands, sometimes they may not need they may not need MRI fistulogram also. So this is overall about fistula in ano disease and its types. There are so much to talk about this, but I would like here to take some commonly asked questions, frequently asked questions, for the understanding of common public and to answer their queries. So few commonly asked questions is, does fistula recur always? So I will say I have talked about so much about the fistula, and there are multiple reasons for fistula to happen again. It has high chance of recurring, but in expert hands and with the use of advanced technology, chances of recurrence are very less, or I can see success rate is very high. But patient needs to be operated by an expert, and he has to do proper follow-ups after surgery. Other question, can this fistula be cured without surgery? So my answer is no. Fistula needs surgery. In very exceptional cases, when the fistula is very small, thin diameter, and it is very subcutaneous, and there is not much of infection, very low level fistula, and patient doesn't want surgical treatment, we can give antibiotics and try to see how it behaves. but most of the time it becomes silent for some time or some months or some year, and then it can come back again. So medical treatment for fistula is not advisable. So some say, is there any way of treating this fistula by Ayurvedic treatment? So in Ayurveda, there is something called as Shar Sutra for fistula and ano treatment. But here I will say, for Shar Sutra, the fistula has to be a straight fistula. It has to be a simple fistula. In Shar Sutra, what happens? The Shar Sutra means thread. The thread which is medicated goes inside the fistula tract from one opening and comes out of the other opening, and it ablates the tract, what we are doing with the laser. But it addresses only that much of tract. But if it has side tracts, then those side tracts, abscess cavity is not addressed, and patient may land up into recurrence. Sometimes it gives false sense of healing. Sometimes it gives that you are healed, and after 2 years and 3 years patients come back with a big abscess and big fistula, and that is why this treatment with Shar Sutra, it may be useful in a diagnosed case of low level fistula single tract. But if it is undiagnosed fistula, if MRI is not done properly, MRI is not done, and there are side tracts and you are using Shar Sutra, then this has very high failure rate. Other thing is, when patient comes for follow-up in Shar Sutra, after Shar Sutra surgery, that thread needs to be tightened, and that is, I am telling you, it is a very painful procedure. Patient is under a lot of pain when that thread is tightened, and it is subjective. Like some surgeon may tighten it very tightly, somebody may not tighten it properly. So considering all this permutation combination, Shar Sutra also is not recommendable for complex fistula, or you can say you can try in patients of low level fistulas. Other question is homeopathy, because sometimes the patient tries to avoid surgery and they go for different pathies, and they ask me, is homeopathy going to treat my fistula and ano? So answer is again no, because homeopathy reduces inflammation, reduces infection to certain extent, but it will not eradicate the tract, it will not cure the fistula disease. Other question, after surgery, will I land up into incontinence, that is loss of control over the stool? Yes, it can happen if the surgeon is not aware of the sphincter complex properly, and if he is not aware what part of the sphincter he is cutting and what part of the sphincter he is preserving. So this, to avoid incontinence, that is loss of control over the stool, you need to get this surgery done with an expert hands. So these are few commonly asked questions. The list is not ending, but I will say, if you have any queries, if you have any doubts about fistula, you are suffering with this fistula, you are frustrated, you are not getting cured, you have undergone multiple surgeries for fistula and ano, still there is some pus discharge, still you are not happy about the anal hygiene in that area, you are frustrated and are not sure what to do, how to treat these fistulas, you are not getting proper answer, then contact us at Apollo Spectra Hospital on the given numbers, and you will get resolved of all your queries, and we will try to treat you completely of your fistula. Thank you, and I wish you all healthy life. And to have this healthy life, I would, as a last remark, I would suggest avoid junk food, drink lot of water, do good exercises, and be healthy. If your nutrition level is good, you are not going to get these infections. So this is the thing. Thank you very much for listening to me. Bye.